Hello. First of all, I must thank the organizing committee of the 2021 Saudi Society of Simulation Scientific Assembly, and especially my dear friend and Mr. President, Professor Boka, for his invitation, as well as Dr. Amani and all the technical staff. I'm really very, very proud, so proud, honored, and pleased to be part of this assembly. Thank you so much. Let me introduce myself, but I think it's already done. I want to just notify that I'm the head of the Morocco Society of Medical Simulation. We called Moroccan SIM. So the Moroccan SIM is working for the promotion and development of simulation in health, as well as educational innovation throughout our kingdom. So for today, I'm very pleased to give this talk about a current topic inherent to pedagogy and COVID. My topic is entitled COVID-19 from Tele Education to Tele-Simulation for healthcare providers in Morocco. So before I begin my presentation, I would like to remind you that I have no financial disclosure or conflicts of interest with the eventual material in this presentation. It will be not possible to talk about training courses without mentioning the famous learning circle. The circle aims at a progressive attitude in the acquisition of skills. It's composed of 5 essential steps. First one, the acquisition of knowledge. Then the masteries of technical gesture. Then computer simulation, such as serious game. Then team simulation, and finally clinical practice at the patient's bed. It's very important to be able to respect this progression for a better pedagogical output. What about the training of healthcare providers and COVID? It should be remembered that training at COVID has 2 main components. First, an organizational component which aims at setting up internal and external procedures for the best management of circuits, the massive inflow of patients, media, families, but also a second component, purely scientific, which is interested in the implementation of care protocols and ensure that they are updated according to the latest therapeutic recommendation. For which target audience is this training addressed? In fact, COVID training can interest several levels, starting from the novice in initial training, then the competent in initial and continuous training, the professional bringing his expertise, and then the expert. Especially in the organizational aspect. What will be interesting is to adapt the content of the training to the target audience. For example, basic level would be offered for the novice, the advanced level to the competent, the specialized level to the professional, and finally the organizational level to the expert. This training also had to have several characteristics. It was very important, both in content and form. In terms of content, the training had to be very flexible in terms of duration, but also in terms of occurrence and content, adapting to the different target audience. It also had to be interprofessional between several health professions. The training had to be interactive and very simple. There were some constraints to be remembered in this context. For example, the training has to be very rapid training, convenience for everyone, adaptable and especially possible at a distance. It's for this reason that tele-education was initially imposed. So let's talk now about tele-education. At the beginning of the pandemic, we organized ourselves into a scientific committee and set up several series of interactive conferences on a web platform, either isolated or in the form of MOOC, massive open online courses. This lecture covered the main aspects of the management of COVID from epidemiology to treatment, including pediatric specificity. In addition to the theoretical lecture, we gave great importance to the demonstration in the form of video clips. Here, for example, was a video clip showing the value of hand washing with the paint and glove test. We also organized all other clips, but this time in the form of live simulations, showing the different stage of the different steps of the management of COVID patients in the emergency and resuscitation department. Of course, all these clips were available on the web platform and downloadable for free. The aspect that was more difficult to implement in tele-education was that of learning how to control the airway, as a human presence was mandatory. We used a hybrid approach in which each participant can learn at the same time, respecting the distance, and the video laryngoscopy screen was remotely connected so that his colleague could follow his performance and progress. For the novices, there were a session of discussion of clinical cases addressing different themes of COVID. These clinical cases were discussed in an interactive way on a special platform and sometimes took the form of simulation scenario well documented with clinical data and iconography. Once the main aspects of COVID management were mastered, we moved to a second level with the novice, namely virtual meeting, the implementation of education gamification process, and finally the discussion of clinical cases through simulation in small groups. Let me tell you that the gamification was really a huge success with all the learners and had a great pedagogical impact. For all the healthcare professionals, a series of online meetings were organized by experts on specific topics related to the management of COVID. For example, this was a remote education meeting on the use and value of lung ultrasound in the emergency department. Better still, the contribution of our scientific societies was very notable in tele-education. I'm talking particularly about the Society of Anesthesiology and Resuscitation and the Society of Emergency Medicine in collaboration with our Morocco team. We had organized two major events. The first one, e-corona meeting, which was followed and seen by more than 78,000 people, but also the e-conference of the Moroccan Society of Anesthesiology and Intensive Care, whose main theme was precisely COVID. Also, in the same sense, Morocco had set up an African platform aimed at teaching and training by tele-education of our friends on different African countries. As you see now on the map as Mauritania, Libya, Djibouti, Guinea, and Burkina Faso. We call this training Morocco e-Corona training. This training was organized in 4 tracks. The first one was about airway and management of airway and ventilation. The second one about hemodynamic aspect. The third one about medical care, and finally, the fourth track is about nursing care. The demand for this training was notable and very, very relevant. So what about the benefit of this kind of distance learning, of remote learning? The first point, attendees can log into a training in any location convenient to them, saving them the time and effort to travel to a specific conference venue or office. The second point, since tele-education training are not restricted to a specific location, stakeholders who are based in other cities or even counties can attend, saving the need to bring in attendees to a central location or have a trainer travel to multiple sites. The third point about cost effective. Indeed, the total cost of running a tele-education training is much lower than hosting a traditional conference. This includes financial as well as labor. And the last point, a training like that can be recorded as part of the broadcast, enabling people to fit the training session into their own schedule at a later time. It will be very interesting for that. On the other hand, let's move now to the limitation of this approach by tele-education. The lower amount of effort required to plan for attending makes it easier for potential attendees to drop out. The second point, not being able to see the audience, the presenter cannot gauge interest, reaction, or mood and adjust the presentation accordingly. The third point, to view the training requires attendees to have compatible equipment and software as well as the necessary technological skills to use them. We need also a stable high-speed internet connection is also necessary. The last limitation is about without the presence of other students or the watchful eye of the presenter, attendees are more likely to try to do multi-tasks at the same time and to complete work or personal tasks at the same time, as I said, which means that are more distracted from the presentation. So to overcome all these problems, a new pedagogical approach is beginning to emerge, namely the concept of tele-simulation. So what is it about? Before answering this question, let's first recall some basic principles of simulation, as Bokar has said in the last presentation. Let's start with the definition. Simulation is about the imitation or representation of one act or system by another. Healthcare simulation can be said then to have four main purposes: education, assessment, research, and health system integration in facilitating patient security and safety. So what's the rationale behind this? Ethics 1. Let's start by the ethics 1. We said all the time, never the first time on the patient. To ensure quality, safety, efficiency of care, and professional medical practice, considering half-life of medical knowledge, transformation of pedagogy, and new technologies. Fans of simulation are convinced that simulation is a real tool. Indeed, it allows contextual learning, it allows reproducible rare events, teaching specific skills, knowledge to patients, and very important, is an essential research tool. On the other hand, the anti-simulation think that it's just a widget, a gadget. We are talking about thinking that simulation giving more high cost, lack of realism, risk of negative learning, giving different emotion, emulating, simulating, and asking ourselves if there is any evidence of validity. Now, let's move to the concept of tele-simulation. Let's start by the definition. We define tele-simulation as a process by which telecommunication and simulation resources are utilized to provide education, training, and or assessment to learners and at an off-site location. Off-site location refers to a distant site that would include the education, training, and or assessment without the use of telecommunication resources. The unifying definition encompasses all areas where telecommunication and, let me say, simulation resources have been used in the past. To talk about tele-simulation, we have to talk mandatory about two theories. The first one, the adult learning theory, and the second one, is the experiential theory. Let's start by the first theory, the adult learning theory. Adult learning theory is premised on several crucial assumptions about the characteristics of adult learners and propose that adults are self-directed and self-regulated. Adults are intrinsically motivated to learn. Adults have prior knowledge and experience that can be built upon of learning. Adults have formed mental models which guide their behavior. And last, adults, we are using analogic reasoning in learning and practice. What about the experiential theory? Experience, either real or simulated, serve as a catalyst for learning, which occurs during reflection and debriefing that follows each experience. Experience provide an opportunity for, let me say, for this reflection, during which individual can evaluate, refine, and enhance mental models that guide their behavior. I will show you this picture. So the process of having an experience, I'm talking about concrete experience, reflecting on that experience, that reflective observation, developing mental models, it's the abstract conceptualization, and then testing that mental model. Active experimentation is based on what is known as Kolb's experiential learning cycle. Tele-simulation helps develop crucial cognitive, kinesthetic, and psychomotor skills of learning by providing real-time, hands-on training that is facilitated by task training and or instructor feedback. Tele-simulation is procedural. Task training has been used in areas such as surgery and critical care fields, assessment of off-site learners, ultrasound, and tele-debriefing. Let's see now what are we doing in Morocco. We recorded several COVID scenarios. We broadcast them on a special platform and thus proceeded to a tele-debriefing with all the protagonists of this scenario. It also sometimes happened to carry out scenarios on conventional simulation with participants respecting distanciation. So conventional simulation scenario, and that the debriefing was conducted with a small group. The same debriefing and broadcast are redebriefed with all the participants. We also recorded a hybrid in situ scenario. In fact, the first part of the scenario was played by a standardized patient. And when we wanted to intubate him, we stopped the scenario and we brought in the high fidelity mannequin to continue the scenario. Finally, the debriefing part was conducted in remote debriefing. It was practically the same concept for the training of the dispatching center assistants. Indeed, we had recorded several audio clips with different accents and constraints, and we made a simulated phone call followed, of course, by a tele-debriefing. We have also created and implemented the first serious game ever on the management of COVID in the doctor's office, a serious game that was designed by ourselves and implemented using the mid-active platform that we thank very much. Another aspect of tele-simulation is that of training in ventilation adjustments of patients intubated for COVID. It was a virtual solution in the form of a virtual respirator, making possible to unfold many scenarios and to follow the evolution of patients according to their respiratory parameters. In the same vein of ideas, we had set up scenarios in tele-simulation, but this time focusing on the hemodynamic aspect of the COVID. This was a virtual monitor with the remote connection. At the end of the curriculum, we unfold complete scenarios combining all aspects of the management of COVID, including respiratory, hemodynamic, but also paraclinic examination to be analyzed. And the last novelty is our board game, inspired by the famous game Monopoly. I wonder if you know this game. It's very known in Europe and Africa. So where instead of buying lots of land, houses, and hotels, the goal of this game, which we named Coropoly, was to build a complete recitation box where the learner was able to take care of a COVID patient. What are the benefits of tele-simulation? Some benefits of this technique, it's about allowing for education and training of learning at off-site location. It allows assessment of learning at an off-site location. It eliminates distance, so no distance barrier to educational content delivery, no time barrier to educational content delivery, and provide added convenience for educational content delivery. Other benefits, it confers benefits of simulation beyond the walls of simulation center. It can provide significant cost saving for individual programs and institutions. It can provide revenue generation for simulation and education center. It allows for inter-institutional networking and collaboration. And finally, it allows for the rapid dissemination of new content in medical education. Implementing tele-simulation into educational curriculum requires resources that include but are, not limited to simulation resources, ranging from simple procedural tasks, trained to high fidelity mannequin or standardized patients. The second resource to use, telecommunication equipment that allows the capture of and transmission of audiovisual data can range from a simple smartphone, computer or web camera, an internet connection, and software that has teleconferencing capabilities. What about the future? The future is a process by which the communication and simulation resources are utilized to provide education, training, and or assessment to learning at on-off-site location. This comprehensive and unified definition makes apparent the critical mass of educational research that has been conducted using telecommunication and simulation resources. Still in its infancy, this area of simulation provides the opportunity for innovating ways to provide education to learning of the 21st century, and also has opened the door for new research with a strong methodological underpinning to evaluate and establish its utility in the field of medical education. Finally, as a conclusion, let me remind you these three case sentences. The first one, never the first time on the patient. The second one, simulation is a technique, not a technology. And the third one that we've created in Morocco, too much simulation, kills simulation. I mean, indeed, remote simulation is good. It's very good. It's very interesting. I'm so happy of that. But still simulation remains good when it's used in a good sense within the framework of a well-defined curriculum. My last slide is concerning our first healthcare training and innovation conference, which will be held in Tangier in the north of Morocco. We will be delighted to see many of you coming and attending our conference. Thank you so much.